Our presentation is on amyotrophic lateral sclerosis, also called Lou Gehrig's disease, and it is a progressive neurodegenerative disease that affects both upper motor neurons and lower motor neurons throughout the body. Regarding to the etiology of ALS, unfortunately, it is not fully known, but research has been discovering that ALS develops as a result of both genetic and environmental factors. Additionally, research has been finding that over 120 genes may play a role in ALS. Some possible mechanisms include genetic mutations, oxidative stress, excitotoxicity, disturbed axonal transport, and neuroinflammation. Some risk variables, which means characteristics or conditions that increase the likelihood of getting ALS, include sports with high concussion rates, being a part of the military, being exposed to smoking, and additionally heavy metals like your magnesium. Also, being exposed to pesticides and electromagnetic fields increase your rate of potentially getting ALS. Transitioning into the incidence of ALS does impact individuals globally regardless of ethnic status. Research has found that there is a low frequency between the Hispanic and Latin American origins. Additionally, research has found that white males under the age of 60 years old are more affected than other groups. There are two types of ALS. There is sporadic and familial. Sporadic is your more common caseloads, which this means that ALS happens randomly. There is no genetic link and there's no family history. However, with familial form, this is where there is that genetic link, there is that family history. The typical onset age is between 55 and 70 years old. And with recent research, they have found that every 100,000 people each year, roughly 1 to 4 are newly diagnosed with ALS. So these are rates ranging from 0.6 to 3.8 per 100,000. To go in depth with this research, they have found that Europe is between 2.1 and 3.8 per 100,000 people each year, with the US being 1.4 per 100,000 people each year. With regarding to the male and female death rate with ALS, males are slightly higher than females, with the male rates being 1.3 and females being 1. Regarding to the neuroanatomy and body structures and functions affected by ALS, unfortunately, it affects both upper motor neurons and lower motor neurons. With the upper motor neurons, it affects the cortical spinal pathway. Then, with the lower motor neurons, it affects the motor nuclei of the brainstem and the anterior horn cells of the spinal cord. Additionally, ALS causes a neurodegeneration that can be found in the corpus callosum, the extramotor cerebral regions, and the frontotemporal lobes. With ALS impacting both upper motor neurons and lower motor neurons, there are a lot of deficits that come with this. This includes weakness of hand or asymmetrical foot drop, progressive loss of muscle movement, spasticity, difficulty speaking and swallowing, loss of emotional control, reduced body temperature regulation, and it can also eventually cause individuals to have respiratory failure. ALS also impacts our cognitive abilities, and this includes our executive functioning, which means it affects our planning and attention and many more. As I said before, ALS does also impact our language abilities.
Continuing on talking about the deficits of ALS, to understand why these difficulties occur, it's important we look at the neuroscience behind ALS. ALS causes degeneration of both upper and lower motor neurons, which are responsible for sending signals from the brain to the muscles. As these neurons break down, the brain can no longer effectively communicate with the muscles. So, this leads to muscle weakness, atrophy, and eventually loss of voluntary movement. These neurological changes directly result in functional deficits. For example, fine motor skills needed for eating and dressing become impaired, and gross motor skills needed for walking and transfers are also affected. When motor neurons in the brainstem are damaged, it leads to difficulties with swallowing and speech. So, this explains why individuals with ALS experience dysphagia and dysarthria, which further impacts their daily functioning and participation. Next, we're going to talk about two specific examples of how ALS impacts everyday activities. So, the first example is eating, which is an ADL, and individuals with ALS often experience hand weakness, which makes it difficult to hold utensils like forks or spoons. They may also have trouble chewing and swallowing, known as dysphagia, which increases the risk of choking. Because of these challenges, individuals often become less independent and may need adaptive equipment or assistance during meals. The second example is communication, which falls under IADLs and social participation. ALS can cause slurred speech or dysarthria, which makes it difficult for individuals to clearly express their needs. This can significantly impact their ability to interact socially and to participate in their daily activities. Overall, these limitations affect both independence and their quality of life.
To review is the ALS Functional Rating Scale, also known as the ALS-FRS, and this assessment measures capacity to perform functional activities for patients who have ALS. There are 12 different items that are administered on the test and multiple categories that those items fit under, which includes the category of fine motor function, which accounts for items 4 through 6, and also the category of gross motor function, which accounts for items 7 through 9. There are other categories, including bulbar function and respiratory function, but to keep it specific to occupational therapy, we chose to dive deeper into fine motor function and gross motor function. The first ability that is measured under the fine motor function category would be handwriting, and this measures a client's ability to write their signature specifically with their dominant hand independently. The next ability that is measured would be cutting food, and that looks specifically at being able to hold and manipulate a utensil, such as a knife, in order to cut food into multiple pieces. The next ability includes dressing, and this observes a client while they are donning and doffing clothes, and also while they are showering. And if specific clothes are required that are easier to don and doff because of limited ability, for example, if it's required to use elastic waistbands and minimize the need for buttons and fasteners, a lower score is indicated because it implies that there is greater assistance needed. Under the category of gross motor function, it assesses the ability of being able to turn around while laying down in bed or other areas of bed mobility. Another ability that is measured under the gross motor function would be walking, and this is classified as standing and walking in a steady manner. If the client was to stumble, a lower score would be indicated, even if walking without assistance. Stepping is also measured under the gross motor function category, and this involves climbing stairs with or without a handrail. And scores of this assessment reflect the progression of symptoms based on the assistance level required to complete ADLs. So the closer the score is to 0, it indicates total dependence, and the higher the score, the more independence a patient is able to sustain despite their limitations due to this illness. The next assessment we chose to review is the ALS-SQOLR, also known as the ALS-Specific Quality of Life Revised. This assessment measures the self-perceived quality of life of patients with ALS. Quality of life is an important factor to consider because ALS is a neurodegenerative disease, and it is necessary for occupational therapists to help their clients feel comfortable and sustain life satisfaction through the occupations that they engage in, even though disease progression will eventually limit their occupational abilities. This assessment can also guide an OT in helping a client manage their expectations as time goes on and their independence levels decrease. There are 6 different domains that are measured in this assessment. The first is negative emotion, which involves depression and anxiety. The second is interaction. This involves a client's perception of their environment throughout the different settings they engage in. The third is intimacy, which involves relationships with friends and family, and also with a significant other and sexual satisfaction. The fourth is religion. This involves engagement in spiritual practices such as ability to read the Bible and engaging in prayer. The fifth is physical symptoms, and this category looks at the extent that ALS symptoms interfere with self-perceived quality of life. The sixth is bulbar function, and this observes throat, mouth, and speech issues that occur because of ALS, and the way that it may interfere with quality of life. Clients are given a list of symptoms or experiences related to the categories above, and they must rate these activities or experiences on a scale of 0 to 10, being worst to best, and scores indicate a client's satisfaction of life based on their perception of these various activities and emotions that they may experience.
The two assessments that Abigail just touched on have to do with looking at someone with ALS and their overall quality of life and functional activities that they do from day to day. And these can both greatly be affected with a disease like this. So we decided to look at a case study to further look into what having a disease like ALS can be like and how it can affect someone's quality of life overall. So, for this study, the main purpose was to look at how early multidisciplinary rehab can impact swallowing and speech in someone with an ALS diagnosis. The idea is that instead of waiting for symptoms to significantly worsen, therapy is started earlier to try to maintain function for as long as possible. The population in this study was a 49-year-old male who had ALS and was already experiencing several challenges, including dysphagia, which is difficulty swallowing, dysarthria, which is difficulty with enunciation and pronunciation of words, and also it can cause slurred speech and other issues and motor impairments. He also had anxiety and depression, and this really shows that ALS affects multiple areas physically on the body, but also the emotional and mental well being. In terms of the study design, it was a case study where the patient participated in a 45-day intensive rehab program. He received around 3 hours of therapy each day, which included speech therapy, physical therapy, and other various swallowing exercises. This kind of multidisciplinary approach and many different types of therapy is very important because it addresses the different ways that ALS impacts daily function rather than focusing on just one area or one specific viewpoint or type of therapy. Now, looking at the key findings from the 45-day study and why they matter for occupational therapy and how OTs can help with people who are diagnosed with ALS or similar conditions. First, looking at the findings, we see improvements in swallowing and speech function, which are huge for maintaining basic daily activities like eating and communication. And along with that, there was a reduced risk of aspiration, which means safer eating overall was experienced. There were also psychosocial benefits, as the man reported decreased anxiety and depression, which is very important because diagnoses like ALS don't just affect the body physically, but they can also affect people's mental health and well being as well. And one of the most important findings of this study was that his functional gains and swallowing improvements were still present at his 2 year follow up. This is especially meaningful because the whole goal of therapy is not just short term, but for the therapy to have carryover into clients' everyday lives and for it to stick with them long term. And then now looking at it from an OT perspective, this directly connects to the role that OTs have as they focus on helping individuals participate safely and independently in daily life activities such as eating, communication, and engaging in meaningful routines. It also reinforces the importance of early and structured rehab, showing that intervention can have lasting benefits even with a progressive condition such as ALS. Lastly, it highlights that OT isn't always about returning someone to exactly how they were before their diagnosis or accident. Our main goal as OTs is actually just to maintain function and quality of life for our clients. And this might mean introducing different adaptive strategies that the person may have not used before their diagnoses or accident, but these strategies may allow them to continue doing meaningful activities in a safe and effective way. And that is what is most important. And that's what OTs really try to focus on.